Caleb Frady, Module 4, Pain Control and Antiemetics.
All right, let's start with the big picture roadmap for this section. We'll begin by breaking down pain perception, how pain is detected, transmitted, and ultimately interpreted by the brain. Once that pathway is clear, the pharmacology becomes much easier to understand. From there, we'll move into common analgesics, focusing on NSAIDs and opioid medications. For each one, we'll approach it the way you need to think in the field: indications, mechanism of action, contraindications, routes, dosing, and the side effects you should anticipate and monitor. After pain management, we'll shift to emesis: why nausea and vomiting happen, how the vomiting reflex works, and why certain triggers lead to vomiting. Then we'll finish with the antiemetics paramedics commonly administer, again focusing on practical application in the pre-hospital setting. By the end, the goal is not just memorizing drug facts, but understanding why these medications work and how to use them safely. Pain perception. Pain perception is a lot more complex than most people realize. Here's a question to think about. Can a patient be in pain without being aware of it? Absolutely. In massive trauma, the body can be experiencing severe tissue injury, but shock, altered mental status, or an intense sympathetic response can blunt conscious awareness. You can see a similar idea in certain chronic pain conditions where nociceptive activity is ongoing, even if a patient's perception changes over time. This is a good place to separate two concepts: nociception versus pain. Nociception is the detection of harmful stimuli and the relay of information about tissue damage to the brain. Pain, on the other hand, is the perception: what happens when the brain interprets that signal. Here's the sequence: a painful stimulus, external like a burn, or internal like ischemia, activates nociceptors. Those signals travel through peripheral neural pathways toward the central nervous system and interact with the autonomic nervous system along the way. Once the brain processes and interprets that incoming information, the patient experiences pain. Now tie in inflammation. When tissue is damaged, mediators like bradykinin, serotonin, prostaglandins, and neurotrophins are released. They cause vasodilation and fluid leakage into the tissues, which is why we see swelling and redness. But the key point is that these mediators lower the action potential threshold of nociceptors. When that threshold drops, the receptors fire more easily and more frequently, meaning more signaling and increased pain perception. That's why injured tissue becomes hypersensitive, and even light touch can hurt. This is also why medications like NSAIDs can be so effective. They target part of that inflammatory signaling.
Inflammation. With that foundation, let's talk inflammation itself. If I asked you what causes inflammation, you'd probably say viruses, bacteria, localized injury, chronic disease processes, and you'd be right. Inflammation is the body's protective response to injury or infection, but it requires one key thing: a blood supply. No vascular supply means no true inflammatory response. Clinically, we recognize inflammation through local and systemic signs. Locally, think of the classic five: redness, heat, swelling, pain, and loss of function. Redness and heat come from vasodilation. Swelling comes from increased capillary permeability and fluid shifting into the extracellular space. Pain comes from nociceptor sensitization, and loss of function is the combined result of pain and swelling limiting movement. Systemically, when inflammation spreads beyond one localized area, you can see fever, increased white blood cell count, tachycardia, increased respiratory rate, elevated blood pressure, and lethargy. The process is coordinated. Mediators are released, vessels dilate, permeability increases, white blood cells migrate toward the affected area through chemotaxis, fluid shifts, and immune activation begins. The end goal is to isolate the injury, eliminate the threat, and start the healing process. Many of the medications we use, especially NSAIDs, work by interrupting parts of this cascade. Non-steroidal anti-inflammatory drugs. Their primary mechanism is inhibition of cyclooxygenase, or COX, which is required for prostaglandin production. Prostaglandins are important because there are many types, and they influence multiple functions throughout the body, not just inflammation. That's why COX inhibition comes with trade offs. There are two major COX enzymes. COX-1 is normally present and plays a protective role. It supports the GI lining, helps maintain kidney function, and contributes to platelet aggregation. COX-2 is more directly tied to inflammation and becomes active during injury, contributing to pain, fever, and swelling. NSAIDs may inhibit COX-1, COX-2, or both. Aspirin primarily affects COX-1. Ibuprofen and ketorolac affect both COX-1 and COX-2. Celecoxibs are more COX-2 selective. In the pre-hospital setting, NSAIDs are most often used to manage fever and mild to moderate pain and sometimes chronic pain flares. But caution is essential. COX-1 effects can increase bleeding risk and worsen GI irritation. So, for multi-system trauma patients or patients likely to need surgery, especially GI surgery, NSAIDs are usually avoided. The main takeaway is that NSAIDs reduce pain and fever by reducing prostaglandin production, but because prostaglandins do more than just drive inflammation, blocking them can create complications. Toradol. Toradol blocks both COX-1 and COX-2, which means it inhibits prostaglandin synthesis broadly. That's also why it's more potent than many other NSAIDs. It's designed for short term pain and inflammation control, not chronic pain management. For adults, the dose is 15 milligrams IV or IO, or 30 milligrams IM. For pediatrics, it's zero point 0.5 milligrams per kilogram IV, IO, or IM, with a maximum total dose of 30 milligrams. In our system, you'll find it under protocol UP11. Operationally, know the packaging. It's commonly 60 milligrams in 2 milliliters, which is 30 milligrams per milliliter, so accuracy matters when drawing it up. Clinically, Toradol shines for inflammatory pain, especially renal colic. Kidney stone patients often have intense prostaglandin mediated smooth muscle spasm and inflammation, and Toradol can significantly reduce pain without the respiratory depression risks of opioids. But the trade off is bleeding risk, since COX-1 inhibition affects platelet function. Use caution in trauma, suspected bleeding, or patients likely to require surgery. Now let's look at Toradol contraindications and adverse effects, because this is where the decision making gets real. Toradol is not indicated intraoperatively or perioperatively due to increased bleeding risk. It's also contraindicated with NSAID hypersensitivity. Renal insufficiency is another major consideration. COX. 1 inhibition can reduce renal perfusion and worsen kidney function, especially in already compromised patients. GI contraindications include peptic ulcer disease and active GI bleeding, since COX-1 helps protect the gastric lining. And we use extra caution in geriatric patients because they're more vulnerable to renal effects, GI injury, and bleeding complications. Side effects include edema from fluid retention, bleeding issues from antiplatelet effects, and nausea. There is also a risk of thrombotic events like stroke and myocardial infarction. These are uncommon in the pre hospital environment, but you still need to understand the risk profile. Finally, adverse effects increase with higher doses and longer duration. Another reason Toradol is reserved for short term use.
Next up is ibuprofen, Motrin, one of the most widely used medications in the world. Like other NSAIDs, it's a COX inhibitor, which reduces prostaglandin production. That gives it three key properties. It's antipyretic, anti-inflammatory, and analgesic. In the field, we mainly use it for mild to moderate pain and fever. Adult dosing is typically 10 milligrams per kilogram by mouth, up to a maximum of 800 milligrams per dose, although most adult doses land around 400 to 600 milligrams. Pediatric dosing is also 10 milligrams per kilogram by mouth using the children's formulation. One important rule: it's not given to patients under 6 months of age. For pediatric fever, we usually treat when it's above 100.4 Fahrenheit or 38 Celsius, not just for comfort, but to reduce metabolic demand and improve overall tolerance. Also remember, many patients take ibuprofen routinely, for acute and chronic pain issues like arthritis. It was originally developed in the 1960s for rheumatoid arthritis, so it's been around a long time and is very familiar to the public. In our system, it falls under UP11 for pain and UP10 for fever.
Even though ibuprofen is common, it's not risk-free. It's contraindicated in NSAID hypersensitivity and should generally be avoided in renal impairment because NSAIDs reduce prostaglandin-mediated renal perfusion. We also use caution in hepatic impairment and in patients with a history of CVA or significant cardiac disease due to increased cardiovascular risk. It's typically avoided around the time of surgery because of bleeding risk. Use caution in asthma as well. Some patients have NSAID, sensitive asthma, and can develop bronchospasm. Side effects are commonly GI related: gastritis, ulceration, abdominal pain, nausea, vomiting, and bleeding, largely because of reduced gastric protection. Kidney dysfunction is a bigger risk in dehydrated patients since renal perfusion is already reduced. You may also see hypertension due to fluid retention. Liver failure is rare but has been reported most commonly in chronic high dose daily use, around 2,400 to 3,200 milligrams per day, or in acute overdose. The main point is simple: common does not mean harmless. Assessment, hydration status, and comorbidities matter. Now let's move to acetaminophen, Tylenol. It's a non-opioid analgesic and antipyretic used for pain and fever. It's often grouped with NSAIDs in conversation, but it's not technically an NSAID because it lacks significant anti-inflammatory effects. Mechanistically, acetaminophen works mainly in the central nervous system. It reduces prostaglandin synthesis in the CNS by affecting cyclooxygenase pathways, though its exact mechanism is still not fully understood and appears to differ from traditional NSAIDs. One key action occurs in the hypothalamus, where it reduces prostaglandin E2 and lowers fever. Its analgesic effect may also involve activating descending inhibitory serotonergic pathways, essentially enhancing the brain's natural pain control system. Because it works centrally, it doesn't provide local anesthetic effects and won't address inflammation in the same way NSAIDs do. Adult dosing is typically 325 to 1,000 milligrams by mouth. Pediatric dosing is 15 milligrams per kilogram by mouth. In our system, it falls under UP10 and UP11. The benefit is that it avoids many NSAID related GI and bleeding issues. But the major consideration is liver toxicity, which is why the next slide matters. For acetaminophen, contraindications include hepatic impairment and active liver disease because it's metabolized in the liver and impaired function increases the risk of toxicity. It's also contraindicated in medication hypersensitivity. Most patients tolerate acetaminophen well at normal doses, but hypersensitivity reactions, including anaphylaxis, can occur, though they're rare. More serious are severe skin reactions like Stevens Johnson syndrome and toxic epidermal necrolysis, or SJS and TEN. These are rare but potentially fatal. They often begin with fever, weakness, and malaise, then progress to a painful, blistering rash that can lead to skin sloughing, similar to a severe burn. 10 involves a larger body surface area and carries higher mortality. These conditions can progress to sepsis and multi-organ failure, including liver, kidney, and pulmonary failure. Finally, acetaminophen's major risk remains hepatic toxicity, typically seen with high doses, chronic excessive use, or acute overdose when toxic metabolites overwhelm the liver's detoxification pathways. The takeaway is that acetaminophen is safe when used appropriately, but dosing limits and liver function must always be considered. Now let's transition into opioids. Opioids treat acute and chronic pain, but they do it differently than NSAIDs. They don't reduce inflammation or fix the source of pain. They change how the brain perceives the signal. Because opioids can be addictive and misused, they're heavily regulated. Mechanistically, opioids act as agonists at opioid receptors, primarily the mu receptor. There are three main receptor types: mu, kappa, and delta, but mu is the most involved in pain perception and also drives many clinical effects like analgesia, respiratory depression, and euphoria. The body naturally produces chemicals that bind to these receptors, endorphins, enkephalins, and endomorphins, and opioids mimic those effects, often more strongly. Clinically, the biggest pre hospital risk is respiratory depression, so monitoring is essential. That means watching hemodynamics, using ECG, and especially waveform capnography, which can catch hypoventilation before oxygen saturation drops. One advantage is that opioids are generally considered surgery safe because they don't increase bleeding risk the way NSAIDs can. The takeaway is that opioids are powerful tools, but they require careful monitoring and thoughtful use. Fentanyl is a potent synthetic opioid, about 50 to 100 times more potent than morphine, so dosing precision matters. It's used for pain management and for sedation during drug assisted intubation. Adult dosing is 50 to 100 micrograms IV, IO, or IM, repeatable every 5 minutes as needed, up to a maximum of 3 micrograms per kilogram. Pediatric dosing is 1 microgram per kilogram, IV, IO, IM, or IN, with repeats of zero point 0.5 micrograms per kilogram every 5 minutes, up to a maximum of 2 micrograms per kilogram. Because fentanyl has rapid onset and short duration, it's particularly useful pre-hospitally. For post-intubation sedation, dosing is typically 50 to 75 micrograms with a maximum cumulative dose of 300 micrograms depending on protocol. In our system, fentanyl appears in UP11, AC4, and AR8. Clinically, fentanyl provides strong analgesia with less histamine release than morphine, which often means less hypotension. But respiratory depression remains the major concern. So, capnography and close reassessment are essential. Now, let's cover fentanyl contraindications and adverse effects. It should not be given to patients with significant respiratory depression, and it's contraindicated in hypersensitivity. Use caution in CNS depression, since adding an opioid can further suppress neurologic status and ventilation. Use caution in head injury as well. If ventilation drops, CO2 rises, and that can increase intracranial pressure. Adverse effects include euphoria, confusion, delirium, constipation, altered level of consciousness, and at high doses, coma. The most clinically important effect is still respiratory depression. Fentanyl also has a strong synergistic effect with other CNS depressants, alcohol, benzodiazepines, heroin, and other opioids, meaning respiratory failure can happen faster and at lower doses. Use extra caution in elderly patients and in severe respiratory or cardiac disease. Bradycardia can occur, and black box warnings emphasize increased risk of decreased respiratory drive in vulnerable populations. The key takeaway is simple. Fentanyl is fast and effective, but it demands careful dosing and vigilant monitoring. Like other opioids, morphine is a mu receptor agonist and alters pain perception centrally. What makes morphine different is its peripheral vasodilation, likely due to histamine release. This can decrease heart rate, blood pressure, and venous return to the heart. By reducing preload and cardiac workload, morphine can ease myocardial oxygen demand, which is why it has historically been used in acute coronary syndrome as well as general pain management. Adult dosing is 4 milligrams IV, IO, or IM with 2 milligram repeats every 5 minutes, up to a maximum of 10 milligrams. Pediatric dosing is zero point 0.1 milligrams per kilogram, IV, IO, or IM, repeatable every 5 minutes, up to a maximum of 10 milligrams. Morphine can also suppress cough through action in the medulla. A key evidence based note: a 2019 systematic review suggested morphine use in ACS was associated with higher mortality, though confidence in the results was low and causation was unclear. There's also concern morphine may delay the effect of oral antiplatelet medications by slowing gastric emptying and absorption. So, morphine remains an option, but its role in ACS is more nuanced and requires clinical judgment. Continuing with morphine, Contraindications include hypersensitivity and significant respiratory depression. Avoid morphine in hypovolemia, since vasodilation can worsen hypotension. It's also contraindicated in GI obstruction because opioids decrease peristalsis and can worsen obstruction. Head injury is a relative contraindication. Respiratory depression can increase CO2, which leads to cerebral vasodilation and increased intracranial pressure, so ventilation monitoring is essential. Side effects include respiratory depression, sedation, nausea and vomiting, diaphoresis, euphoria, syncope, orthostatic hypotension, constipation, and flushing from histamine release. The key point is that morphine affects multiple systems: respiratory, cardiovascular, and GI. So reassessment and monitoring are non negotiable. Hydromorphone is a mu receptor agonist and also exerts effects in the medulla. This is where I like to pause and ask, what's located in the medulla? The respiratory center. So, just like other opioids, hydromorphone has the potential to suppress respiratory drive. Adult dosing is 1 to 2 milligrams IV, IO, or IM, with a maximum of 5 milligrams. Pediatric dosing is zero point 0.1 milligrams per kilogram IV, IO, or IM. Contraindications include asthma, especially if the patient is already in respiratory distress, and GI obstruction, since opioids slow peristalsis. Use caution in head injury and elevated intracranial pressure for the same reasons we've discussed with other opioids. Hydromorphone is effective analgesia, but it requires the same careful respiratory monitoring and reassessment you'd apply to any opioid. Now let's shift to ketamine. Ketamine is a dissociative anesthetic and it works differently than opioids. Its primary mechanism is glutamate receptor antagonism, specifically at the NMDA receptor. Blocking NMDA receptors disrupts excitatory neurotransmission and produces both anesthesia and analgesia. Ketamine has some mild mu receptor activity, but that's not the main driver. One of ketamine's advantages is that low doses can provide pain relief without full dissociation, so you can manage pain while minimizing deep sedation. This makes it useful for pain that is not responsive to opioids, or when opioids aren't ideal due to hypotension or respiratory concerns. Ketamine also increases sympathetic tone, which can raise heart rate and blood pressure. Because of that, we avoid it in patients with stroke, elevated intracranial pressure, hypertension, significant cardiac disease, glaucoma due to increased ocular pressure, and hypersensitivity. Protocol wise, under UP11, ketamine is advised against in combination with benzodiazepines due to increased respiratory depression risk. Ketamine can be used alongside opioids, and a multimodal approach, smaller doses of each, can provide strong pain control while reducing total opioid exposure. The takeaway is that ketamine is powerful and versatile, but patient selection is critical because of its sympathetic effects. Now let's go one step deeper into how we administer ketamine clinically. The mechanisms are the same: NMDA antagonism, producing analgesia and anesthesia, but the practical point to remember is that rapid IV push is associated with more side effects. Giving it slowly, IV helps reduce adverse reactions like emergence phenomena and abrupt hemodynamic changes. Low dose ketamine remains one of the most useful tools for analgesia without full dissociation, especially when pain isn't responding to opioids or when opioids create too much respiratory risk. Because ketamine increases sympathetic tone, we still avoid it in stroke, elevated AICP, hypertension, significant cardiac disease, glaucoma, and hypersensitivity. And again, under UP11, avoid combining ketamine with benzodiazepines due to increased respiratory depression risk when CNS depressants stack. Ketamine can be combined with opioids in a multimodal strategy, often improving pain control while reducing overall opioid load. Bottom line, ketamine works differently, often preserves respiratory drive, but must be administered thoughtfully and in the right patient. Vomiting is a common pre hospital complaint, and it's also a frequent side effect of opioid administration. The vomiting center is located in the medulla, which is a good reminder that nausea and vomiting are centrally coordinated reflexes. Vomiting can be triggered several ways. One pathway involves muscarinic receptors in the vestibular system, your inner ear, which is why motion sickness causes nausea. Another involves the chemoreceptor trigger zone, or CTZ, located close to the medulla. The CTZ detects emetic agents in the blood, like toxins, medications, and metabolic disturbances, and communicates with the vomiting center. It contains serotonin receptors, dopamine receptors, and even mu receptors, which is why opioids can trigger nausea. A third pathway starts in the GI tract, where serotonin receptors and vagal nerve stimulation send signals to the brain. The vomiting reflex itself is coordinated. The lower esophageal sphincter relaxes, the diaphragm contracts, abdominal pressure rises, salivation increases, the epiglottis closes to protect the airway, and then expulsion occurs. Understanding these pathways matters because antiemetics work by blocking specific receptors within this system. With those pathways in mind, antiemetics make a lot more sense. We classify them by which receptors they block. H1 antagonists like promethazine, Phenergan, primarily target histamine receptors and work well for vestibular or motion related nausea. 5-HT3 antagonists like ondansetron, Zofran, block serotonin receptors in both the GI tract and the chemoreceptor trigger zone, making them great for medication induced nausea and common EMS nausea complaints. D2 antagonists like metoclopramide and droperidol block dopamine receptors in the CTZ and are often helpful in migraines, gastroparesis, and dopamine driven nausea patterns. Muscarinic antagonists like scopolamine primarily target vestibular causes like motion sickness. One clinical note: promethazine works on multiple receptor pathways, roughly 3 out of the 4 major triggers, so it can be effective across a wider range of nausea presentations. The takeaway is that different antiemetics target different pathways, and the best choice depends on the likely cause and patient specific risks.
Promethazine has antihistamine, antidopaminergic, and anticholinergic effects. It's often described as an H1 blocker, but it also blocks dopamine in the brain, especially in the chemoreceptor trigger zone. That dopamine blockade is why extrapyramidal symptoms can occur. Movement disorders like dystonia or involuntary muscle contractions. Promethazine is also sedating, and it can potentiate other CNS depressants, including narcotics. So if an opioid has already been given, be mindful that the combination increases sedation and respiratory depression risk. Administration is also critical. Promethazine must be diluted prior to IV use. The recommendation is at least 100 milliliters of normal saline infused over about 20 minutes or deep IM injection. This matters because promethazine is very irritating to tissues. An improper IV administration can cause significant burning, vein irritation, and even tissue injury. Adult dosing is 12.5 milligrams IV, IO, or IM, and it may be repeated once. It is not used in pediatrics in the pre-hospital setting. The main takeaway is that promethazine can be effective, but it requires careful administration and monitoring due to sedation, tissue irritation, and dopamine-related side effects.
Continuing with promethazine, contraindications include hypersensitivity in pediatric patients. Promethazine is contraindicated in children primarily due to the risk of fatal respiratory depression, and it has been associated with severe respiratory suppression, hallucinations, and seizures in pediatric patients. Side effects include sedation, confusion, hypotension, and paradoxical excitability, especially in the elderly, where some patients may become agitated instead of sedated. Because of anticholinergic effects, you may see dilated pupils, blurred vision, dry mouth, and urinary retention. Cardiac effects are also possible, including prolonged QT and rarely torsades de pointes. And again, dopamine blockade can cause extrapyramidal symptoms such as dystonia, akathisia, and tardive dyskinesia. These are medication induced movement disorders linked to dopamine inhibition. The takeaway is that promethazine is effective but carries meaningful respiratory, cardiac, and neurologic risks, so patient selection and monitoring matter. Ondansetron is a 5-HT3 receptor antagonist, meaning it blocks serotonin receptors involved in nausea and vomiting. In the GI tract, serotonin can bind to receptors and trigger signals through the vagus nerve up to the vomiting center. Zofran blocks that binding, so those signals never get sent. It also works centrally in the chemoreceptor trigger zone by blocking serotonin receptors there as well, which gives it both peripheral and central antiemetic effects. Adult dosing is 4 milligrams IV, IO, or IM, and it can be repeated once if needed. Pediatric dosing is 0.2 milligrams per kilogram IV, IO, or IM with a maximum of 4 milligrams. Zofran is generally well tolerated and doesn't carry the same sedation risk as promethazine, which is why it's commonly used as a first-line antiemetic in many EMS systems. Now let's finish Zofran by focusing on contraindications and safety. Zofran is contraindicated in hypersensitivity, severe liver disease, and suspected GI obstruction. If a patient has a mechanical bowel obstruction, nausea and vomiting are symptoms of a bigger problem. Zofran may reduce symptoms, but it doesn't fix the cause. Use caution in patients taking medications that prolong the QT interval, in patients with electrolyte abnormalities like hypokalemia or hypomagnesemia, and in patients taking azithromycin or a Z-Pak, because these factors increase the risk of QT prolongation. The QT interval represents the time from ventricular depolarization to repolarization, basically the electrical recovery period of the ventricles. The QTC is the corrected QT, adjusted for heart rate. When QTC is prolonged, the ventricles take longer to reset electrically, which increases the risk of torsades de pointes, a potentially dangerous polymorphic ventricular tachycardia that can deteriorate into ventricular fibrillation. The risk increases with IV administration, higher doses, electrolyte imbalance, and other QT prolonging drugs. The FDA does not recommend a single IV dose greater than 16 milligrams due to this risk. In EMS, we're typically giving 4 milligrams, sometimes repeating once, so we're well below that number, but you still need to think critically. Side effects are usually mild, with headache, dry mouth, and constipation being the most common. The rare but serious concern is QTC prolongation, and the risk is higher in long QT syndrome, cardiac disease, and electrolyte disturbances. The takeaway is that Zofran is highly effective and usually very safe, but when you give it IV, especially in cardiac patients, consider the ECG, QT interval, medication interactions, and electrolyte status. As you move forward, remember that medications are tools, but your understanding of physiology is what makes them effective. When you understand how pain and vomiting actually work in the body, you're no longer just giving drugs, you're making informed, patient centered decisions that improve outcomes in the field.